Hi, my name is Issa Smirstik. Support for this episode and the following message come from Audible, where you can get access to nearly 200,000 audiobooks. I recommend The Ghost in My Brain, How Concussion Stole My Life, and How the New Science of Brain Plasticity Helped Me Get It Back. This book needs no further explanation. This book or any other can be yours for free for 30 days if you sign up on audibletrial.com/brainwaves. That's audibletrial.com/brainwaves.
We are also supported by Blue Apron, where you can have farm-fresh meals delivered straight to your door in a weekly refrigerated box. Because food is better when you start from scratch. Get $30 off your first delivery by signing up through our blog at brainwaves.me. Hey guys, Jim here. In honor of the new academic year for interns and residents, taking on their new roles in the hospital, saving lives, working harder and longer than they ever have before, we're dedicating this episode to you all. You have your finger on the pulse of the academic hospital, and you are the reason it continues to operate at such a high capacity and with such incredible efficacy. And you work for pennies on the dollar. Today, we're going to be talking about how long you'll be working for. As in the hours of the day, not the decades of your life. Totally different story. Joining me is Dr. Ali Hamidani, who you'll recognize from several older episodes about the relationship between the brain and the eye.
Well, up until the end of June, I was a neurology resident at Penn, and then starting July 3rd, I'm a neuro-ophthalmology fellow here.
But there's more to him than neuro-ophthalmology.
I mean, I do like to cook, I like to swim, run, kind of.
Ali, welcome back to the show. As you know, today's episode is going to focus on one question. But before I ask you my question, let me just give the non-medical listeners some context for this episode. In the early 20th century, U.S. doctors in training, meaning interns and residents, they often worked 36-hour shifts with 12-hour breaks. By the 1980s, the U.S. government began to realize that this could be a problem. Not surprising. And we're going to talk about why. But since then, the government has restricted the number of hours a resident could work to the traditional 80-hour work week. How those hours are divided is a separate issue. With the 80-hour work week came the caveat that first-year resident physicians, interns, could only work 16 consecutive hours, whereas the more senior residents could work up to 28 hours at a time. But everybody gets a minimum of 24 hours off every week, on average. I'll admit this is a very brief summary. So here's my question. Is it more important to let residents work more consecutive hours or fewer consecutive hours?
So I think there are a few different interests that are balanced in this whole duty hour debate. One is the quality of resident education. The argument is that more time spent in the hospital, especially continuously, allows for more learning to occur during a longer period of time and also more continuity. So the same patient that you manage several times in the middle of the night due to various complications. Another interest is patient safety, with the argument there being that longer hours result in more resident fatigue and more medical errors that are made, and so shorter shifts would minimize that, with the caveat being that shorter shifts equals more handoffs between residents, and there's a potential for errors to occur or information to be mistakenly misheld or not adequately passed along during those handoffs. And then a third interest, I think, that we don't talk about as much is resident preference. So I happen to prefer 28-hour calls to night float. And it's because I, as a resident, was never really able to adjust well to a night float schedule. I'm not nocturnal by nature, I guess. So I always found night shifts hard to get used to and quite kind of socially isolating.
What's the consensus that you feel after working with many residents and interns that they want as far as 28 hours or 24 hours or 16 hours a shift?
I don't know. I think I hear a mixture of opinions. I think also it depends on what you're doing during those shifts. If it's consultative work, then I think the concern about errors occurring due to sleep deprivation are maybe not as great of a concern, especially if there's someone that you're discussing ideas with, because there's another physician there that's already providing a little bit of backup, and because you may not necessarily be actively titrating as many different things, or certainly procedures are involved, and I think it's a very different story, because sleep deprivation, I think, is of great concern when you're involved in a surgical procedure or something like that. If it's direct patient care, then also I think the concern of mistakes being made due to sleep deprivation, I think is maybe a bit more readily apparent when you're actively taking care of patients rather than seeing them in consultation. Well, I guess one thing that does occur to me as we talk about this is how much your perspective on this question of duty hours depends on what position you're in. So right now we're talking having just finished residency. I'm sure the opinions I express would be totally different if I were an intern and we were having the same conversation.
Sure, as an intern, this shift from a relatively normal life and a relatively normal sleep schedule is dramatically changed. And that 28-hour shift that you said that you preferred, maybe that's not what the intern would want. And particularly if you were a surgical intern, spending countless hours in the operating room, wielding sharp objects over open abdominal cavities, that's probably not something you'll want to be doing after 20 or 24 hours of wakefulness. So, physician preference is important, and sadly it's one of the least recognized components out of all of this. But much of the drive to change resident duty hours really stemmed from safety precautions. So let's talk about this.
Some of the incidents that inspired duty hour regulations to begin with were actually not precipitated by surgical errors. They were precipitated by medical ones, which I guess I find kind of surprising because I always think of procedures as the area of greatest concern when it comes to sleep deprivation. So there were a few memorable cases, one that occurred in New York.
Ali is absolutely correct here. It was not a surgical error that really launched the movement to reduce resident work hours. It was a medical error. Libby Zine was a freshman at a small school in Vermont in 1984. She had depression, and she'd been on a single antidepressant medication, phenelzine, which is a monoamine oxidase inhibitor. She took it every day. In the middle of her second semester at college, she developed flu-like symptoms, and she was admitted to a local academic hospital, one that was staffed by resident physicians. Overnight, she became agitated, and the on-call intern prescribed meperidine, which is an opioid anesthetic, a pain medicine. And later that on-call intern prescribed Libby some haloperidol over the phone, because Libby's agitation was interfering with her treatment. Not an unusual scenario, actually, and I can't even remember all the times that I prescribed haloperidol over the phone for an agitated patient. But it's easy in hindsight to recognize that the combination of 3 different psychoactive drugs, a monoamine oxidase inhibitor, meperidine, and haloperidol, they can interact with each other. Today, we know that these medications together will increase your risk of serotonin syndrome, which can lead to irreversible multi-organ failure. But this interaction was not well known in the early 80s. Together, these medications precipitated a severe reaction in which Libby developed an uncontrollable fever to 170 degrees Fahrenheit, she became unarousable, and she would later die that evening of a cardiac arrest. This was a truly horrible event, and unfortunately one that has happened many, many times since then. But long hours weren't the culprit here. Nobody blamed the patient census that these residents maintained. It wasn't as important to the lawyers that the on-call resident was caring for dozens of patients besides Libby. Nobody blamed the on-call pharmacist for not reviewing the potential medication interactions. Nobody blamed the nurse for not checking in on the patient more frequently when she was agitated or developing a fever. I mean, nobody even blamed the fact that we as physicians have the right to physically restrain patients if we believe that they're posing a threat to their own health. And we can still order nurses to tie down patients to their beds, even today. But none of this is in question here. It was only a matter of hours that the intern had slept, which everyone believed had impacted her judgment in caring for Libby.
You know, one thing that I often think about when I am kind of thinking about these kinds of questions is the urgency of the clinical scenario. So Jim, as you all know, is going into stroke, which is a very acute field of medicine. It's a lot of split-second decisions, a lot of acute decisions that you don't really get to redo again, whereas I have the luxury of going into an outpatient specialty with some complex decisions, but one that which you get a little bit of time to sort them out. And so I'm thankful that I made that decision. I'm probably not the person that you want managing stroke or other kind of things like that. But I bring this up because whenever I'm discussing consult with someone, or I'm on call this weekend talking to ophthalmology residents who are seeing neuroophthalmic consults, I very often we like discuss a plan, and then I hang up on the phone and then immediately think of something else to add, which rarely actually changes the whole plan, but it's just sort of like an additional something like, oh, by the way, might want to add this to our discussion. And on one hand, I'm glad that I remember that, or that I didn't forget to pass that along. But then sometimes I think like, well, if that were really important, or if this were like a situation where you made a decision to give TPA, you can't really take that back afterwards. Then I sometimes wonder like what that says about my thought process, or does that mean that I was too rushed, or I didn't really think of everything in the beginning?
I think that raises a very important point too. I think we are ignoring a lot. Right now, we're focused so much on the number of hours that a resident or an intern spends in the hospital. But what about those hours that are spent at home when someone's on home call and may not be as engaged with the patient who their interns or their other co-residents are evaluating? Is there something to be said about taking calls from home and not having the full picture and then still making recommendations?
Yeah, so certainly making recommendations based on indirect information, i.e. not reviewing data and examining the patient directly, is challenging, but I found it a really rewarding experience, and one that inevitably most physicians will encounter at some point in their careers anyway, whether it's as simple as giving a patient advice over the phone about their upper respiratory symptoms, to making recommendations about medication administration to emergency medicine physicians or something like that. This brings up the whole field of telemedicine into and kind of how that's evolving. So it definitely brings some new challenges, but I've actually grown to really enjoy it.
So I'll interject here by saying not many residency programs utilize a home call system, meaning a system where the residents work from home and they can deliver recommendations over the phone to an in-house resident or an intern. Where Ali and I worked, we had a home call system, and this poses some interesting challenges like the ones that Ali mentioned. One thing Ali did not mention, however, was that the hours that we spend at home don't actually count towards that 80-hour work week. So if we were on the phone for 8 out of the 10 hours that we had off, then those 8 hours count for nothing, and I'd still be expected to return for another full day at the hospital. Now, I'll say that I actually enjoyed this home call approach. It really does teach you a lot about how to become an effective clinician when you're dealing with that indirect information that Ali mentioned. Do you have any kind of general advice you would give to new interns, new residents who are now either as residents taking on a 24-plus hour call cycle, or interns who may be taking 16 or 24-hour call cycles that's entirely new to them?
Well, I guess certainly everyone has their own strategies for how to optimize your wakefulness, whether it's caffeine timed at a certain day or a certain time of day. I think to me the biggest thing is just to make sure to ask for help whenever you need it. And it's something that residents in general, but especially early residents, often feel uncomfortable doing. You don't want to be known as the weak one or the one who needs the most help or something like that. But I think it's important to ask for help when you need it to avoid mistakes, prevent mistakes from happening. And so that can be as simple as I'm not so sure about this. Could you just double check or something like that? I think that's one of the nice things about having someone to bounce ideas off in the middle of the night too, as opposed to being by yourself, is that in talking to someone, often you realize things that you missed along the way.
I agree. I think you're exactly right. We've spent the last 8 years of our training in college and medical school trying to become autonomous and to take care of patients independently. And when we're finally in that situation where we can do this, I think that some interns are, and I certainly am in that camp, where we are less reliant on others. But as a senior resident, when I saw that type of behavior pattern in the interns that I worked with, it was a little startling and kind of scary, because they don't know the mistakes that they could possibly be making yet, because they haven't had the experience or the exposure to the types of patients that they will eventually have. And I honestly think that it's more impressive that the interns or the students came to me and asked me questions about what to do in this situation, or am I doing this correctly, or what could I be doing better in this situation?
I agree completely. I feel like earlier in training, I similarly was eager to have more autonomy and to not feel like there was someone looking over my shoulder all the time. But as I have moved up, I actually kind of crave that supervision a little bit more. I think there's a balance between allowing someone to make decisions independently, but then still being there to verify them, sort of a trust but verify kind of situation. I also really appreciate trainees who begin the process of kind of thinking independently but aren't afraid to sort of welcome other opinions or things like that.
Absolutely. I totally agree. In 1988, 4 years after the death of Libby Zion, the American College of Graduate Medical Education, the ACGME, published their first recommendations on duty hour restrictions. Residents must be allowed 1 day off in 7, and they could not take call more frequently than every third night. A year later, the Review Committee for Internal Medicine instituted the 80-hour workweek for resident physicians. By 2003, the ACGME modified this 80-hour workweek to include a stipulation that residents could not work more than 30 consecutive hours at a time. In 2011, the Institute of Medicine felt that the 2003 standards had done little to reduce resident fatigue or improve patient safety, so a 16-hour work limit was enforced for the new interns. But many physician trainees, Ali and myself included, didn't like it. And medical educators struggled with providing additional hospital coverage for the hours of manpower lost from the 16-hour limitation. Others argued that this limited the amount of teaching for the new trainees. So, this year, they have actually redacted the 16-hour work limit for interns. As of July 1st, 2017, interns can officially work for as many hours as their senior resident physicians, 28 hours at a time. I guess we will see what this means at the interim review in 5 years when the ACGME plans to revisit duty hour regulations. That's all we got for Brainwaves this week. We hope this has been at least a little informative. For more information about what was discussed, we always include references in our show notes. Our production staff includes Erica Mejia and me, Jim Siegler. Music by Jazar and Jason Shaw. We are supported in part by Audible, the world's largest source for audiobooks, and Blue Apron, delivering you fresh ingredients and simple instructions for making delicious home-cooked meals. For more information on these services, check out our blog at brainwaves.me. We're also on Facebook and Twitter, so you can find us there as well. I'm Jim Siegler, and with that, good luck to all the new residents and interns this year. Wishing you the best.